But I do really love my job. There are so many small parts of it that make it so wonderful. And I think there are so many tiny elements of the job that are so important that I really, really enjoy. And also, it is just so interesting.
People are endlessly fascinating. There's a real sense of synergy in an era of immense technological sophistication. We can sit in a room with someone and give them an opportunity to make their lives a bit better and maybe add a bit of value. And I kind of think that's wonderful.
Hi, everyone. Welcome back to this week. So, this week you've got the joy of all three of us. So, it's Anya, and we've got Bex and Alex here. Well, not really here with me, but in spirit here with me. And we're going to talk about what a day in the life of a psychiatrist is like. So, I hope that you can get some very different perspectives because Bex and Alex have had some quite different journeys and quite different work lives. We've had some questions come through, so thank you to those of you who've written in, and hopefully we can answer some of them as well. As ever, if there's things that you're interested in sharing with us, drop us a line on Instagram or on email, and we'll have some of those details at the end of the episode. So let's start off with some introductions. I wonder if we can start with Bex, if you could tell us a bit about where you're at in your psychiatric training and what your journey to get there has been like.
Thanks, Anya. It's weird being on the other hand, on the other side of the podcast. So I am currently a CT2. That stands for Core Trainee 2, level 2. So I completed my foundation training, which is the first 2 years after you qualify as a doctor. And then I spent 6 months being a kind of trust grade, is what we call it. So you're not on a training program per se. And in those 6 months, I worked on a CAMS inpatient ward, so child and adolescent mental health ward, for 6 months. And then I began my training back in February 2021. And then, so I did 1 year of CT1 and now I'm in my second year. So I'm a core trainee level 2. So in psychiatric training, as a doctor, you, at least where we work, you rotate every 6 months. I think some people do training programs where you rotate every 4 months. But here at the Maudsley, the most common training program is every 6 months.
Alex, can I cut to you and find out a bit about what your journey to where you're at the moment has been like?
Sure. So, like Rebecca, I've done my 5 years of medical school and then I did my 2 years FY1, FY2 in Scotland. Then after that, I worked freelance for a year in different specialties, including mostly general surgery and general medicine, actually. Then I did my core psychiatric training, which is what Rebecca is doing now. So that's 3 years. Then I did another year of freelance work, mostly in psychiatry. And now I've done 2 years of higher training, and I've got just about 9 months left of higher training before being a consultant. And just like Rebecca, I rotated through a bunch of 6 month placements in hospitals and clinics and different mental health services. And I'm also training in psychotherapy at the Metanoia Institute in West London.
And where are you working at the moment, Alex?
So right now I'm working in South London in a split job, which involves 2 days a week on a hospital ward, treating men with acute mental health problems, and 2 days a week at an early intervention clinic, which means a clinic for people who have had one episode of psychosis. And so the service really focuses on treating this group of people and trying to prevent them from having future episodes of psychosis, trying to optimize their lives, trying to prevent them from being readmitted to hospital. And then on Mondays, I do my master's classes at Metanoia for psychotherapy. And on Wednesday evenings, I actually see my psychotherapy clients, which is also kind of a part of that program.
So quite a varied week. And I'm wondering about that split job, how that works, what is nice and perhaps about seeing people through a kind of journey from early to hospital admission, and what's challenging about splitting yourself in two as well.
It is a bit challenging because you only do 2 days a week on each job. So you feel it's hard to feel fully embedded in either. So instead, what you end up doing is trying to think, on every day when you're in each job, how can I make myself most useful it's nice because you get to see a lot of the same patients. So patients that I see in hospital who would have come in with their first episodes of psychosis, I then can tell them, I'll be one of the doctors following you up in the community. And so I think one of the problems with NHS services that are set up at the moment is there's often a lack of continuity of care. Inpatient doctors tend to be different from outpatient doctors. It wasn't always like this. But for the first time in my career, I've had this opportunity to actually see people in the inpatient environment, take care of them or help to take care of them when they're really acutely unwell and when things are really difficult, and then be part of that transition to the community and part of the medium to long-term recovery. And when I interviewed someone for the podcast who had schizoaffective disorder, who had a psychotic disorder, one of the things they thought would be really good was if inpatient doctors and outpatient doctors were the same person, to keep that continuity of care alive.
Which is something I think that, like you say, used to be much more commonplace. And I think some places still have a bit of that model. And it's interesting to hear that from a patient's experience that's what they like. But it sounds like from your experience as a clinician, there's something that is quite satisfying about being able to follow patients through that journey for you.
Yeah, I think one of the most rewarding things about being a clinician is about seeing people across time, really, seeing how they improve and being able to form a relationship with them that can survive the ups and downs. And when you really begin to work together as people, I think. And it's very difficult to do that if you only see people when they're acutely unwell. And similarly, it can be quite difficult to do that if you only see them after they've been through this very difficult period, which you're not familiar with at all. And we're constantly in that situation as doctors because we're constantly rotating through these 4 to 6 month rotations, which of course we kind of have to do to get exposure and training in different environments. But then we miss out on one of the best parts of being a clinician, in my opinion, which I think then people start to realize when they become consultants and get to see people hopefully for longer periods of time.
And I'll come back to you, Alex, for your perspective on as you approach that part of your journey. Bex, I wonder if I could ask you a bit about what you're doing at the moment, because I know that your jobs have been quite different to what Alex has described, and I wonder what perspective you have on the patients journeys that you've seen.
Yeah, so where I'm working at the moment is really quite unique. So I'm working on the anxiety disorder residential unit at the Royal Bethlehem Hospital within the Maudsley. And it's kind of one of a kind, really. It's a national service, and we treat a number of mental health conditions, but mainly we treat OCD, body dysmorphia, and some emetophobia as well. They're the main diagnoses that the people that we see and treat. In the country, it's one of 2 inpatient services within the NHS that mainly treat OCD, body dysmorphia, so anxiety disorders. And there's another service not so far away from us, but the criteria to get onto that unit is a little bit different to ours. So it's quite unique. I wouldn't say it's your classical core trainee job because there's only one of them. It's with Professor David Veal, actually, who came on the podcast to talk about OCD, which is a really interesting podcast if you haven't already listened to it. It's interesting what Alex mentioned about following people, because I think we're quite lucky. We have residents come and stay for 16 weeks. So I'm actually quite lucky enough for the first time in my psychiatry career to actually see a change in someone, because they're your patients and they're residents with us for 16 weeks. And I agree with Alex. It's the first time I've actually really had prolonged contact with someone, and I've seen them improve from their mental health condition. And that's such a rewarding thing. It really just reminds you why we do this job compared to previous jobs that I've worked on, where you're on an acute psychiatric ward and people come in and they're there for a week and you discharge them, and you have to move really quickly because the beds are so needed in the NHS, and ideally you want them to stay for a bit longer, but we're under so much pressure, and you don't really get to see them on the other side. They're well enough for discharge, but you don't get to see them really benefit from becoming better. So yeah, I completely empathize and understand what Alex is saying. I feel really grateful to be able to see that change.
It's a really important balance that you highlight, because I think something, certainly when I was applying to psychiatry, I think a misconception that a lot of people around me had is that people don't get better. And I think that is a misconception that is changing. But I think you point to an important, I think, balanced position that you do get to see some people get better as a psychiatrist, but you have to be prepared for the fact that depending on where you're working and what you're doing, you may be part of that journey, but you won't necessarily be the person who sees them recover because of the way that services and systems are set up. I wonder how you deal with that, or whether that's something that you think about on the rotations where you've had less continuity, or where you, like you say, where you're meeting patients quite quickly and they change quite quickly and you don't get to see them for that long.
It sucks. I think I hate it, because some patients you really, really, care about so much, and seeing someone you care about so much and feeling like you can't help them, not that you haven't tried, it's horrible. I'd like to think we offer some help regardless. I'd like to think you can offer a tiny bit of help, but it's such a horrible thing, caring for someone and really trying, and not seeing an improvement. I don't know. What do you think, Alex?
I think when you only have a brief chance to work with someone and you just get to see a snapshot of someone, I think it can be quite hard. I think you have to embrace it as something that's unavoidable in many circumstances.
Yeah.
And I like to take the mindset of, if I only even have 10 or 15 minutes with someone, and there'll be many patients who I've encountered, and you only have 10 or 15 minutes, you think, how could I make these 10 or 15 minutes the most useful? And I think earlier in your career, it's tempting to think about it as me helping them. And I've changed my perspective on this with time, especially in psychiatry, and especially with people with psychological difficulties. I think it's more helpful to think about it as opening windows of opportunities for people, which they can or cannot walk through. So if you see someone briefly with, for example, problems around emotional instability and relationship difficulties, and you're only going to see them once or twice on a ward, say, you use that, half an hour to an hour to the best of your ability. You try and, as clearly as you can, impart to them what you see as the truth of their situation in a way that can be helpful, and a way that's couched in compassion and empathy. And you try and give them the high quality information that you think they would really benefit from, signposting them to this service or that service or this way of thinking about things. And then you have to kind of leave it up to, I don't say chance, but you have to let it go, and you have to let the patient or the client make the best use of it as they will. And a lot of medicine is like that, unfortunately. I think it's tempting as doctors. We always want to take control of situations and fix people, and maybe surgeons can fix people, because they literally open them up and can fix like a mechanical problem. And maybe we can fix people a little bit sometimes with medication. But I think for the most part, what we're doing is, rather than just helping people, or rather than just having the idea that you fix people, you try and provide an environment for them to help themselves, which is a lot more true to general life, I think.
I wonder what in your training has been helpful to shape that way of thinking for you, Alex, because it sounds like you've changed your position a little bit from viewing your role as a very doing to role, and a maybe slightly less omnipotent, or less a different role. I wonder what your trajectory to that has been, or what you found helpful to your thinking.
Well, probably a lot of it is because of my exposure to schools of thought within psychotherapy, which revolves a lot around this. Psychotherapy really elaborates well how you can't really make people do what they don't want to do, even if that course of action would benefit them. Carl Rogers, who founded person-centered therapy, talks a lot about this. You really want to create the conditions for people to grow in the best way possible, but it's not something you can really do yourself. So on one hand, I've had a lot of experiences where I found it's not very effective for the patient or the client, actually. It's not the best strategy because often when you try and make someone do something they don't want to do, you just create animosity between the two of you. But it's also very important from a self-care perspective as a clinician. You can hear Rebecca's pain, when she's talking about she really wants to help, but sometimes you can't. And when you see hundreds and then thousands of patients and clients, you start to realize also the best way to take care of yourself is to have a more realistic view of where you can slot in to someone's life. And actually, it's I think very unhealthy for the clinicians as well to adopt this approach, because if you're constantly trying to fix people and you constantly see it as your responsibility as to whether or not they get fixed or not, then you're going to exhaust yourself. And I kind of see, I think that, and I've had experiences in my personal life as well. How many of us have friends where you could probably in 5 sentences point out, exactly what they need to change about their lives? And how many times have you told them those 5 sentences? And how effective has that been? It hasn't been effective at all, because actually people don't want you to just point out what's wrong with them. People basically want to make their own decisions. And when they're ready, they'll ask you. And if they're truly ready, they'll ask you. And if they have the right environment and they feel nurtured and they feel comfortable. But you can't just be like, you just need to, if you just stop doing A, B, and C, and D, even though you might be right. But a lot of good relationships in healthcare and in one's personal life aren't about being right. Being right is highly overvalued.
Yeah, agreed. Some people were quite curious to hear, what is a day like, be that as a core trainee or as a more senior psychiatrist. So I wonder if you could give us an idea, be it in the rotation that you're currently in or from a previous rotation, if you think that highlights something, a bit about what an average day or an average week might look like. Bex, what do you think?
So I'll speak about previously as well as currently, because as I said, my job's pretty unique. So classically, as a core trainee, you will have at least one job on an acute inpatient ward. So on an acute inpatient ward, you're treating some of the most unwell patients. And some or most of the patients will be under a section of the Mental Health Act. And they're there basically to ensure their safety or the safety of others. Whilst an individual is on that ward, they can leave sometimes if the risk is considered to be appropriate and come back. And some people aren't allowed to leave, so they really are on that ward within the walls of that unit. So as a core trainee on that ward, you've got a few key jobs. One of those jobs is seeing the new patients that come on the ward and taking a full history. This is your opportunity to find out everything you can psychiatrically, but also physically about that individual so that you can treat them uniquely as best you can. So from 9 to 5, when you're working on the ward, which you typically do, you see your new patients and have a 1 to 2 hour conversation. Sometimes it takes longer, sometimes it takes shorter, depending on the mental state of that individual, to find out everything you can about them. You also primarily manage the physical health of your patients. You may have other doctors in your team as well, such as registrars or foundation doctors or GP trainees there to help you. But primarily, you're going to be the person to look after their physical health. And we know that physical health in those with mental health conditions, especially severe mental health conditions that lead someone to need to be admitted to a mental health ward, people with these conditions tend to have poorer physical health. So that can be quite labor intensive. Other jobs you do is unfortunately not the best job, or personally the one thing that I dislike the most is documenting. So typically once or twice a week, you'll have a ward round where the consultant or the registrar or you will see a list of the patients. It might be all the patients on the ward, it might be half of them, depending on how many people are on your ward. And typically the core trainee has to document the conversation that you have with them. And that ward round is to check in with them, discuss how their treatment's going, discuss their medications, things that you're basically doing for them while they're on the ward. Discuss their leave as well, which is usually really important to individuals, because you imagine no one wants to be kept on a ward for a long period of time. It's really isolating and really distressing, and also really boring. So unfortunately, that is probably one of the worst parts of the job, is documenting and writing what everyone says. And other than that, if you have time, depending on the wards you work on, you can talk to the patient, see if you can help them in whatever way you want as a core trainee. We have teaching in psychotherapy, if you have the opportunity and the time to do that. And depending on how busy your ward is, I've worked on some wards that are very busy, so acute male or acute female, slightly less busy, older age, psychiatric wards. And recently I worked on a CAMS, psychiatric intensive care unit. We had less patients because the work was more intense, but also I was able to spend a lot more time with my patients doing some of the psychotherapy techniques that I'd learned during my teaching. And now my current job is a little bit different. We have ward round once a week, and then for the rest of the week I can spend quite a lot more time with my residents, my patients, doing some of the techniques that I've learned in teaching.
I think that captures it really well in terms of what is our job, what is it that we do.
Yeah,
I wonder if you could speak a little bit to what might be different outside of 9 to 5, because I know that you said some of those things are what you might do, you know, what we call our day job in our 9 to 5, but you do on calls as well as a core trainee. What do on calls involve? What does that mean to a non-medical listener?
Yeah, a massive part of being a core trainee is doing on-calls. And what on-call means, which I didn't know until I became a doctor. Throughout medical school, I was too embarrassed to ask what it meant because I just assumed everyone knew, but I didn't know. On-call is when you're working outside of 9 a.m. till 5 p.m. And typically, depending on where you're working and how many wards there are, there'll be 1 or 2 doctors there covering from 5 p.m. till 9 p.m. and then from 9 p.m. to 9 a.m. 9 p.m. to 9 a.m. is the night shift, and 5 p.m. till 9 p.m. is the evening shift. And that's typical. I haven't worked in many places, but where I've worked, that's the typical hours that you do. And when you're doing those, you attend to emergencies, or you attend to seeing new patients on the ward. So like I said, if you're working 9 to 5 and you have a new patient, you see them. You also have to do that between 5 and 9. Sometimes patients might have physical health complaints that need to be seen urgently, and you have to attend to those. Or sometimes you also have to go and see people that have come to A&E with a mental health condition and need to be assessed to see how we can help them at that moment in time, whether that be with community follow-up, whether that be with an inpatient admission if their mental health illness is so severe that they present a risk to themselves or others, whether they need a period of assessment on a ward. Or sometimes, and this is also quite important to know, if someone's mentally unwell and they're found on the street by the police can detain an individual under section 136 of the Mental Health Act, or if someone's mentally unwell in the home under a 135, and they can then take them to what we call a place of safety, and that's either A&E, or we actually have place of safety suites. Here at the Maudsley, we have a few rooms. Other places I've worked have just one individual room. And as the on-call doctor, you may be called to go and assess them, and again, assess what the next plan of action can be for that individual to ensure the best course of treatment for their mental health condition.
You've spoken as well about the physical health care that we provide to our patients.
Yeah.
And I wonder if you could touch on who might help you with that, or if it's common that you might send someone to A&E or ask their GP to do follow-up of treatments that you start. What kind of things might happen from a physical healthcare perspective in a mental health hospital?
So something that lots of people don't know is that on a mental health hospital, you don't particularly have the capacity to give people IV lines, so that's water into the vein, unless it's in an acute emergency, and we only have a certain amount of oxygen on the units. So if you have a physical health concern and you're a patient on a mental health hospital, we have quite a low threshold to send individuals to A&E for further investigation. And I think that's something that you really need to be aware of as a core trainee doctor. Be aware of your limits of what care you can give. And so if you think someone needs further investigation or may even deteriorate, even though they don't need it right then, the safest thing to do, and every situation is different, is send someone to A&E. And that's something that we often do, because at the end of the day, it's better to be safe than sorry. So yeah, that's something that we often do. Or alternatively, we can call our colleagues, our medical or surgical colleagues in the hospitals, seniors there, such as registrars, and ask them for their opinion on a situation. That's also something that I often do. It's difficult because we don't have all the equipment that you would have in a general hospital, but you just have to be aware of that and act cautiously.
So I think, what you highlight is really important, so that there are things that we can do, but there are things that we can't. And so for that reason, we're really grateful, obviously, for our A&E colleagues. And it's important, I guess, as a patient as well, to be aware that depending on what you're experiencing, you may well have a trip to A&E just to make sure that everything is okay.
Yeah, exactly.
Alex, I wonder if I could get your perspective on what a day looks like as you move on through training.
Yeah, so rather than talk about my day, I'll talk about my week, because one of the really interesting things about being a registrar, and what I tell core psychiatric trainees, is the registrar years can be the best years, because you really start to have the space to start to consciously design your own career. And I think we're moving out of a space where people are forced to take parts which have already been laid out for them. And now I think more than ever in 2022, we're free to carve out our own parts. And one of the best things about higher training is you have a special interest day. So every day you can do whatever you want. So for me, that's Monday, and I'm doing my psychotherapy training at Metanoia then, with my classes all non-medical. So it's me and a bunch of other psychotherapy students. And psychotherapy training is nuts, because it is 8-hour days where we are being trained to be aware of our psychological states and being trained to express them spontaneously and easily, and to become less defensive individuals, I would say, and to become very good at openly expressing ourselves and becoming very comfortable with even the negative aspects of our psychology. And obviously we learn about theory as well. And we do practice therapy sessions in front of each other. We even do fish bowls, where you will do practice therapy in front of 10 of your classmates and your tutor. So it's very intense. It's very different from medical training. And I think it's very useful for as like just general life skills. So that's Mondays for me. And then I have 2 days in hospital wards, which are Tuesdays and Fridays. And that's treating patients with quite acute, severe mental health problems, usually things like psychosis, manic episodes, severe depression, things like that. And on those days, my job really is to, along with the consultant on the ward, to try and figure out what's the best treatment for this patient at this time. And typically in this phase of a patient's journey, medication is quite a big deal. Other psychological aspects and social aspects play a role, but medication is really at the forefront when you're trying to get someone who's really unwell and trying to get them well enough so they can be discharged home. And then on my other 2 days where I'm in the clinic, that's all about how do you optimize everything else. And I see people for more routine appointments, less for emergencies. And often it's about either changing medications to give people less side effects, or reducing the doses of the medication to get them on the minimum effective dose, sometimes stopping medications altogether, and making arrangements for like psychology, psychotherapy, and social interventions, trying to get people into work, trying to get people other forms of social support. And then on Wednesday evenings, I'm seeing my formal psychotherapy clients. So this could be anyone from the general population, not necessarily someone with a mental health condition per se, and can be something like mild anxiety, depression, relationship problems, people with specific issues, like they want to stop smoking, or people who want to lose weight. So then it really opens up to quite a wide variety of issues. And I really enjoy that because it's really, medicine can be very algorithmic, where you see the same problems again and again, the same 2 or 3 issues. Whereas in psychotherapy, you see such a wide variety. You have to be a dynamic problem solver. So I really like that aspect of psychotherapy.
I just want to draw attention to what you said right at the beginning, which is absolutely wild. You get a day a week to do something that you're interested
whatever you
in.
want.
Whatever you want.
Oh, and I should mention, of course, in between all of those things that Rebecca mentioned and I mentioned, and in between Anya's job as well, we're making podcasts as well.
The key part, the unforgettable part.
The best part.
The best part, absolutely. So something that you've drawn attention to, Alex, is how varied and how many different skills and hats you wear in your week. And I think it's something that you touched on, Bex, in terms of the skills that you're developing through training. And something that one of the listeners was interested to know was how you managed to learn all of those different things that are important. Your skills in psychotherapy, your skills in managing social situations, your skills in having an awareness of physical health, in listening to your patients when they tell you that they're having side effects and they need their medication changed. How have you developed to balance that, or how are you developing to balance all of those things?
So I would say, again, just getting back to the distinction between carving out your own path and following a path someone has laid out to you, which I think is really important. The way you do that is by accruing a unique combination of skills, or not necessarily unique, but an uncommon combination of skills. Because when you do that, you can command a higher value than someone who just has one bog standard set of skills. Now, the way you do that, the way you get that very uncommon combination of skills, is by following your passion and your fascination. So I don't want to make this like a corny, follow your dreams and everything will be all right. But yes, follow your fascinations, because you will have specific fascinations that not everyone else has. You will have a specific combination of fascinations that most people don't have. So not only does that make you uncommon, but it is the fascination that will drive you to learn all the skills. And this is the difference between a job and a career. Chris Rock, the comedian, had a really good joke about this, or a really good segment about this, where he talked about the difference between a job and a career. A job, you can't wait to clock out. 5 o'clock comes and you're tired of it fundamentally. You're not fascinated. When you have a career, there isn't enough time in the day. And you could work on it endlessly. And the fascination is the engine that drives you to learn all the skills fundamentally. It's the undercurrent. So that even on your weekends or your evenings, or even in conversations you're having with people, you're continuing to read and watch and listen and learn about the topic. So, like, speaking personally, I like to read about psychology and philosophy and medicine and biology because I like it. And so it's not I'm doing it because I have to do it for my job. I made it my career because I like it. And if you do that, then it becomes a very organic process, because the truth is it takes thousands of hours to accrue these skills. So it's not like there's no cheat code. There's no like the shortcut to becoming an expert in anything. It's the fascination will drive you to do the ridiculous amount of hours of work that will take you to become really, really good at something and to be able to command a niche. And if you want to have a truly unique career, that's what you want. That's what you're aiming to do. You're aiming to command a niche.
What's your perspective, Rebecca, on how you balance all of the different things that you're trying to learn as you go through core training? Alex also touched on philosophy and, your psychopharmacology skills, as in your prescribing skills, your people skills. How has that been in your training time?
If I'm being completely honest, I try not to think about it too much. I try,
Not
I'm
like
trying
not
to
like
just
me
trust the
then.
process. I am just, if I'm being honest, I think I'm just trusting the process and I'm really loving it. So it seems to be working okay for me. And I think, I hope that's a really rubbish answer, but that's the truth. I think genuinely because I love my work, I love what I do. I come home and I know I'm happy. And yes, when I it's difficult if I have a difficult day, but deep down I know that I'm loving what I'm doing.
Yeah.
I still have the ability to separate what I do. I don't know how exactly or why, but I just it seems to be working for me at the moment, and I'm not thinking about it too much. We are lucky enough in psychiatry, which I think is really important, that we have lots of space to talk about the difficult elements of our job. So, as core trainees, we have a group every Wednesday in your CT1 and CT2 year, where I work, at least at the Maudsley, where we talk about difficult cases in a group, and it's the same group for at least 6 months, if not a year or 2 years. We also have supervision where we have a long case where we give psychotherapy to an individual, and every week we discuss that with our supervisor. Typically, we always have a supervisor no matter what we do. So, in your job, your 6 month job, you have a clinical supervisor that supervises your clinical work. But throughout your 3 years of core training, you also have an educational supervisor. And from my own experience, they've always been on hand for me to discuss any difficult issues that I'm having in my work and also just discuss the positive things that are going well as well. So, for example, in my current job, I see my supervisor once a week, every Monday, and I can discuss anything I want. It tends to be at the moment things that I just find interesting because luckily enough, I'm really enjoying my work, but there's always someone there to talk to. And also, I've found that the people that do psychiatry tend to love talking about psychiatry. And if you're on call and you're working with a colleague and you're not busy at that current moment in time, you still talk about psychiatry. And it's probably quite therapeutic. Like I said, I don't think about it too much. But you have that space to discuss the things you feel you need to. When I said we're on call, we see someone to assess them and decide a management plan. You typically discuss it with a senior, and that's your opportunity also to discuss what you've seen. So there's so much support. I'm lucky enough, and this may not go on forever, and I'm sure we all have ups and downs, but so far it seems to be working really well for me, and I truly love what I do, and I'm just not if it's not broken, don't fix it. I don't think that might not necessarily be the best psychiatric advice, but that's me just being honest.
I think the amount of support and the training that we receive in psychiatry training is a huge benefit of being on this kind of training scheme.
Yeah.
So it is incredibly supportive, both in terms of your development as a person, your reflective ability, your the training that you have to get better at what you do. And I think that's can be a unique part of careers, and I think is a really special part of psychiatry training.
One other thing I think is really important, I'm just going to say, is that we also have the time to be people outside of our jobs, because typically you do finish on time, unlike other jobs in surgery or medicine. And I know that from my friends that they seldom leave on time. Typically, as a trainee, you do leave on time, and you don't work every weekend. Your weekends aren't too frequent. Your night shifts aren't too frequent compared to other jobs in medicine. So you have the time to have an outlet to do whatever you want to do in your social life and your personal life. And that's super, super important too, where you can just switch off and be the other person you are that's not in your career.
Yeah, especially because if you want to be adept psychologically, you have to live life, right? You have to make your own mistakes. You have to have a wealth of relationships in your personal life. You'd be a terrible psychiatrist if you didn't have an active personal life or social life.
Yeah, completely.
How do you manage the challenging parts when they come?
Lots of ways. I'm in therapy, which is a part of my therapy training, but I think whether or not I was doing psychotherapy training, I would have done a course of therapy anyway. So I've been in therapy for almost 3 years, once a week, which is very helpful for lots of reasons, to explore the depths of one's own psychology, but also for problem solving in a more present moment sense. And an active social life and friends where you can talk about, things which are totally unrelated, and interest in music and physical activity like lifting weights, which is the most unpsychiatric, unintellectual pursuit, which is just such a good way of getting out of your head and de-stressing. So all those ways, really.
It's something that people often ask, whether we have our own therapy as psychiatrist trainees. And I think it's something that's perhaps more common in other parts of the world and used to be more common in the past, I think, in the UK as well. So it's interesting that you talk about it, because it's not something that's compulsory necessarily in training, but can obviously be very helpful.
And weirdly, there's still, and in the UK, there seems to be some stigma about psychotherapy within psychiatry that I've noticed, where actually psychiatrists aren't sure about psychotherapy, actually unsure about whether or not they should get it. They're not sure if it makes them weird. They're not sure if it makes them broken, which is surprising. And I don't think that's really true on the continent. I don't think you'd find the same attitude in Germany or France, for instance. But it seems to be present. I think it's a shame. I'm not entirely sure why that is. It may be that in the UK, psychiatry selects for people of a more conservative, typically medical mindset, and maybe they're less open to it, or maybe we've just doubled down so much on a more medical model, psychopharmacological way of looking at things, that we see psychotherapy as still very archaic. But that's what I've noticed.
I know that if you specialize as a psychiatrist who also works primarily as a psychotherapist, in those cases, everyone goes through their own therapy. But like you say, it seems to be less commonplace or less normalized for whatever reason in the other specialties of psychiatry. I wonder why that might be as well. And if anyone has any perspectives, do write in. I wonder, I'm going to bring us towards a close in the next sort of 10 minutes or so. But I wonder what perspectives on your jobs I've perhaps not asked you about that might be important to share or interesting to share, or that you were thinking about as we were having this conversation.
I feel like I haven't really sold it. I know that this isn't my place, but I feel like when I discussed the day in the life of a psychiatrist, I didn't make it sound that great. But I do really love my job. There are so many small parts of it that make it so wonderful. And I think we touched on that at the beginning, which is helping people get better, or helping them help themselves to get better. There are so many tiny elements of the job that are so important that I really, really enjoy. I guess I couldn't really explain them all in one go.
Can you give us a taste? What are the kind of little things in your day that you really love?
Just interactions with my patients, seeing a tiny improvement. I think it's quite easy to explain where I'm working at the moment, because I'm working on a ward primarily that treats OCD, and seeing someone shake my hand, for example, which might be a massive exposure to someone with OCD. See someone pick up a strawberry with their hands and eat it. These are just tiny examples, but little things like that just really spur you on and really show you why you're doing the job that you're doing. And also, it is just so interesting. That's me personally, and I know that's bias. I don't know what you guys think. You must think that too. But it is absolutely fascinating. And I do hope that it's something that will improve during my career, because I'm not denying how difficult it is. And I'm not denying how hard it is for someone to get treatment in the NHS. I think that's something that's not great, that we can't deny. I'm in no way denial of how difficult it is for someone who's struggling to access help. And that's something that's actually really negative part of our job, is we can recommend treatment services, but whether or not those things actually happen is another question. And that's something that is really, really rubbish. And I'm not sitting here saying I love my job, it's all roses or anything. I'm not denying how difficult it is.
And I think that's an important caveat to come to, is that it's the aim of today really was to share a little bit of a window into what it's like to do this job for anyone who's curious, or for anyone who's thinking about applying for psychiatry, or just for someone who wants to learn a little bit. There's lots of issues in organizations and in the systems that we work in, and also in individuals that we work in, and lots of difficulties for patients. And we have and we will continue to share those voices and those difficulties as well. But hopefully there's a little bit of insight into what the working day can be like from the perspective of someone doing the job. Alex, I wonder what kind of thoughts you might have.
What I love about my job, my career, is firstly, I don't get Sunday dread. Like, maybe I get a bit of Sunday overwhelm, but I don't get Sunday dread. I don't dread going to my job ever. What I really love about it is, firstly, people are endlessly fascinating, as Rebecca said. And secondly, there's a real sense of synergy, because you can learn stuff in your personal life and share it directly or indirectly with your clients and patients to help them. You can learn stuff from your clients and patients that you can apply to your personal life and to people around you. And so if you allow it to, and if you're willing to kind of surrender to it in a way, it can become this very wonderful process where you get to refine and work on your own self-improvement, and then become really good, hopefully, at sharing that around you and trying to add value to people's lives. And then it becomes this whole lifestyle where you're hopefully adding more and more value to yourself and to the people around you. And that is just, and you get paid to do that. And you get to do it with minimal, like, you don't need a lot. You end up in a place where you get to sit in a room with someone and add value to their lives. You know, in an era of immense technological sophistication, which is dazzling and yet sinister and a bit dangerous, but dazzling. You know, we have this very old school way of, we can sit in a room with someone and give them an opportunity to make their lives a bit better and maybe add a bit of value. And I kind of think that's wonderful.
What a lovely place to pause. Thank you both so much for giving us a little bit of an insight into what life can be like as a psychiatrist, what a career can look like, and what some of the challenges and what some of the enjoyable parts of your day are as well. I will bring us to an end and allow us all to say our goodbyes. Thank you so much for listening, and thank you for coming on, Rebecca and Alex.
Thank you. Choose psychiatry. Hashtag.
Definitely choose psychiatry. Thank you so much for listening to this slightly special episode of the podcast. We hope that you learned something that was interesting or surprising, and if that was the case, we'd love to find out. If there's something that you'd like to know more about, or if there's an episode that you think would be great for us to do get in touch. You can contact us on social media, either on Instagram or on Twitter, or you can email us, and we'll have the details for that in the show notes. And as ever, if you find the episode valuable, or if you enjoy the podcast, we'd love it if you shared it with a friend, or if you gave us a rating on either Spotify or Apple. And if you fancy it, you can even buy us a coffee, and all the links for that will be online. Thanks again.